Well, thank you very much for the opportunity to speak here today. We heard a great message last night from the bishop, and hopefully I can add a little something to that. I am here just to talk about the medical aspect of isolation, violence, hope, and communion. We spent quite a bit of time on this. Is that better? Can you hear me okay? In the back. If you can't hear me, raise your hand. So we've spent quite a bit of time on this problem. As a trauma surgeon in a busy metropolitan trauma center, where we take care of 7,000 injured patients a year between myself and my 10 partners. We live, eat, and breathe violence. It is a terrible problem, a scourge on mankind, and we really would like to do something about it. We spent a lot of time in the past on trying to prevent people from getting injured. We've influenced the automobile industry starting in the 1960s, car seats and fall prevention, all sorts of things. This violence thing has a life of its own, and we're trying to come to understand it. While I have no disclosures to make, I will tell you that I am a life member of the National Rifle Association, and that I am a gun owner and enthusiast. That has maybe some influence in this presentation today that you should be aware of. What I'm going to talk about and provide today is the American College of Surgeons' viewpoint on a public health solution, potentially. We have more questions than answers on firearm injury prevention. This is just one aspect of violence, but perhaps the most lethal of those things. And the impulsivity that comes with suicide related to firearms is a huge problem in this country. So we're going to review some things, we're going to lay some groundwork, I'm going to give you some personal examples, and then I'm going to tell you what a group of hundreds of surgeons thinks about this. And these are the people that care for these injured victims on a day in and day out basis. The American College of Surgeons Committee on Trauma is nearly 100 years old. And there are regions that are around the world that total more than 3,500 members of this committee on trauma. We have an injury prevention and control committee, and I sat on the executive committee of the American College of Surgeons for about 6 years and have been a member of this firearm strategy team work group to try to figure out what we can do to stem this tide. This is that group of folks that have worked on this for a long time, just regular people from around the country that are very interested in having people not hurt themselves or hurt one another. We have a bevy of things that we have put together over time to teach people how to care for the injured, as well as how to try to prevent injury. We oversee trauma centers around the country to make sure that the quality of care rendered is appropriate in those places, and we'll be joined tomorrow by the Chicago segment of the Committee on Trauma for a special session at 10 o'clock on how to stop bleeding. What all of this requires is a very collegial environment. We listen to all viewpoints, try to come to consensus at every point, and we try to base that as best as we can on available research and data. So this issue is a public health problem. As much as the world would like to make this a political problem, it really shouldn't be. There's a ton of evidence to support that you can change a problem if you apply your resources to it. But what this is going to require is that we talk with one another. And I think His Grace said this last night in a way that hit home with me, is that when you have a conflict between your mind and your heart, you should put your mind in your heart and view the issues from that perspective to set aside conflict. This comes from John Bowman, circa 1916, so over 100 years ago, from the American College of Surgeons, where he felt that philosophers ruled the world, and that you have to choose, you have to find and express thoughtfully the personal equation of your lives. I don't want to take care of another person who's been shot or has shot themselves. None of us want to experience that. The fewer holes there are in people, the more lives that will continue. That's at the core of what we believe about this problem. So we have dedicated ourselves to the service of humanity, and we use science as best we can to help us to do that. And so this is a different kind of philosophy that comes from this book, The 15 Commitments of Conscious Leadership, that facts are facts, but your interpretation of those facts and the way that you string them together and tell your story is just that. It's a story. And that if you hold on to your story tightly, that leads to this conflict. You can't release that, and you can't listen to another person's point of view. So you should hold on loosely to that story and listen to what other people have to say, lest you learn something or change your mind. So there are two polarizing viewpoints on this issue. That on one side of this equation, guns are a right, and it leads to personal protection, and it's paramount to our freedom. On the other side of this equation is that guns are equal to violence, and they actually limit our freedoms. And how do you find the common ground in the narrative to keep people from harming themselves or one another? This is a huge study in terms of injury related individuals belonging to two major academic organizations in this country dealing with injury. And what you can see is that not quite half, but approaching half, believe that firearm ownership is beneficial, and the other equal part thinks that it's harmful. What I guess the point is that the trauma community is as equally divided as it would seem as the citizens are in our country. And over time, this disparity, this difference has grown larger, which does not make solving any problem easier when you get further from common ground. So violence is a problem. Yeah, it's a huge problem, especially when you take into account self-harm and suicide. There's a lot of folks here who deal with this on a daily basis, with your patients, those who you counsel, those who you care for, those who you pray for. And preventing injury is paramount to what I do on a day-to-day basis. 180 citizens of this country die every day related to intentional violence. About 70% of those are related to self-harm, and about 30% are intentional harm against another individual. Overall, nearly 40,000 citizens in this country die each year related to firearm injury violence when you total all of those things together. For every individual that dies, there are 9 or 10 other individuals who are admitted to a hospital with serious injuries related to firearm injury violence. It is a terrible burden on this society and on each and every one of us and the families of those individuals. When you look at all intentional injury over time, this has climbed, whereas unintentional injury related to something like motor vehicle crashes has declined. We've invested quite a bit in safer roads and safer vehicles and law enforcement, etc. And this is evidence that you can solve a problem, or at least make a big change in that, in the degree of that problem, when you put your resources to bear on that issue. And so when you look at patients that we care for in trauma centers around this country, firearm injury is just a tiny little piece of these injured patients and the ones who die. But again, by lethality, it's equivalent to all those other things, even though the proportion is that small. And so this really gets our attention, especially when we start to look at children and children involved in shootings. And so this is adults and children. You can see suicide numbers going up, homicide numbers going up over the past 10 years or so. And in fact, when you look at car crash deaths of children dating back to the late 1990s, and those deaths in children related to firearm, what you can see is that gap is rapidly closing. We have solved a problem with traffic-related deaths between car seats and better engineering and airbags. We have not solved this problem related to firearm injury. And what you can see is that unlike motor vehicle crash deaths, which really affect children the most in a rural type of environment, firearm injury doesn't discriminate by your location. And so that's, it is ubiquitous across all aspects of our lives. Dating back to the 1950s, what you can see is that sadly we have now reached a point where firearm injury related deaths are surpassing motor vehicle crash deaths per population. So if intentional violence is the problem, and we have 180 people dying every day, 60% of whom die related to firearm injury, and that it's a major problem in both children and adults, and this is just 1/10 of the issue in terms of the overall burden of this disease process. We have not kept pace with the things that we have done in one small area in terms of traffic-related deaths. So how can we solve this? Why would we solve it? And how would you go about it? And what would you need to do to make a difference? So the why really comes down to the needless death and suffering of our patients, their families, our neighbors, those in our communities, and it's again ubiquitous across this country, across this globe, and it affects our patients, our colleagues, our friends, our co-workers, our communities, our neighborhoods. It affects our cities, our elected leaders, and it's a huge problem. So I'm going to take you back, it's nearly 2 years to the day that in a place not unlike this, just quite a bit warmer, southeast of San Antonio, in the First Baptist Church of Sutherland Springs, there was a mass shooting during services that day. This is the trauma region that I come from, and the partners that we have that work on solving injury-related problems, responding to events that are inevitable, that are going to happen, be they motor vehicle crashes or natural disasters, etc. It's a really good working group of folks. This is that area of South Texas. It's 22 counties. It's about 26,000 square miles, which is as big as the state of West Virginia. And what you can see is that not every county even has a hospital in South Texas. While the city of San Antonio is replete with hospitals, you're still quite a bit away, because actually where Sutherland Springs sits is way down here in this little corner, about an hour and a half away from San Antonio by ground. We're prepared for this, and we've spent a lot of time, energy, and money planning for it, to have buses that can act as miniature hospitals to respond to events such as this. We practice, we drill, etc. But nobody expects that on a Sunday morning you're going to have a mass shooting and have to respond. As it would turn out, on that day, the American College of Surgeons was visiting our trauma center to verify whether or not we could take care of trauma patients. And so our entire faculty was present in the building as it would turn out. And we had a number of residents that were there with us, et cetera. And we even had a visitor from our neighboring Army Trauma Center across town at Brooke Army Medical Center. This is the page that went out when the shooting began, that notified all of us that there was something going on and that we needed to be prepared to respond to this event. With a potential of more than 30 patients in a mass shooting headed towards San Antonio. In the 7 minutes from the time that that shooter entered that church, there were 46 of the 50 people in that church shot. And there were over 200 agencies that responded to this event to try to make a difference. There's at Sutherland Springs, as we had talked about. The closest hospital, Connolly Memorial, is a critical access 20-bed hospital that's got about 4 units of blood in the fridge, in the blood bank. And so if we didn't respond to this event, you can imagine what else might have transpired that day. Overall, sadly, there were only 13 patients for us to take care of because the majority of those individuals were dead. They're not faceless, nameless people. So we learned a lot. How to be better prepared, how to respond. Turning those present into responders, which is one of the things we're going to do tomorrow in one of the sessions, in a breakout, is teach people how to stop other people from bleeding to death. So I think the why is answered, but the how comes into question. So it's going to require dialogue from a variety of viewpoints to achieve a consensus. And if we keep the patient in the middle of that equation, that victim, then I think that we can do that. Again, paraphrasing something that, as Grace said last night, we should have a bias for action. That we can talk a lot, but until we act, nothing's going to change. So, excluding people and excluding their ideas, excluding their dialogue is not going to help us solve this problem. At least so says the former Chief of Staff of the United States Army, Martin Dempsey. So, inclusiveness, if we take that in this context with this particular problem and say that you have freedom but you have a responsibility at the same time, that if you can have that dialogue, it should generate trust and lead to more durable solutions. So is that possible? Well, we sat around, we had a lot of conversations about this. That you know, on one side of this equation, the general benefit of firearm ownership and the negative aspects of having people have guns. But I think that there are some facts that are just written, you know, out that firearm ownership is a liberty. It's guaranteed by the Constitution, that violence is a major cause of preventable death and injury. And we can reduce death and disability by working together, understanding and addressing the underlying problems, and make firearm ownership as safe as possible. So creating policies is really difficult, but that's what it's going to take for us to get past this. And so maybe starting with where we agree instead of where we disagree is the right way to go. So again, a number of surveys of thousands, actually, of surgeons around this country was undertaken. And what you can see is that the majority support some legislation to be able to address this issue. While equally divided on whether or not firearms are beneficial, had no bearing on the fact that legislation would be necessary. But things like preventing people with serious mental illness from having a firearm achieves great consensus. That increasing penalties for those doing things with firearms illegally gains tremendous consensus. That enhancing a background check system becomes paramount. Father John, are you here? Father John Hedges, he's a law enforcement officer. And what Father John will tell you is that what's lacking in the national reporting system is what happens locally. And that when that police officer pulls you over for speeding, they punch in your license plate into their little computer, and they know every 911 call that's gone to your house from that local jurisdiction. I lived for 8 years in Minnesota, and in order to exercise my right to buy a firearm, I had to go to the local sheriff, and I had to submit my background, my information, so that the local sheriff could look and see if there were any 911 calls. It doesn't have to result in a conviction. Just a 911 call for domestic violence, anything like that, and I would not have permission to submit myself to a national background check. And so you had to have local law enforcement. It's a fantastic system. I don't know of a Minnesotan who disagrees with that system because it adds a layer of safety to things, and we think that there's some enhancement that could be done in that regard. So even looking into private firearm sales, we think should be accomplished. Removing firearms. I heard there was some discussion last night. Someone here at OCAMPR had spent the last couple of days creating a safety plan related to potential interpersonal violence in a relationship related to this issue of removing firearms from someone who is a danger to themselves or to others. Improving mental health screening and treatment. for individuals and advocating for unrestricted, non-partisan related research. Because if you don't understand what the problem is, then you need to study it. And if you do not have funding available to be able to research this, you're never going to get to the root cause of this issue. Garners tremendous support amongst this group of people who live at that cutting edge, if you will, pun intended for surgeons, that have to deal with this on a daily basis. Federal database, mandatory licensing, age restrictions, not so much consensus on those issues amongst this group. So it's a huge problem with so many aspects to it. It's very complicated. And the difference between self-harm and interpersonal violence is stark, but probably not that far apart from each other. And we have not done ourselves any favors by politicizing this and not funding research into it. So what could we do? Well, I think that if you were interested in bicycle safety, you probably would go to bicyclists and ask them, what can we do? How can we do this better? How can we make your ride safer? Same here, is that if you don't engage firearm owners in this discussion, and I will tell you on the record, 8 years ago when this first came up at the American College of Surgeons, I said, unless you engage the NRA, you are not going to come to a solution on this problem. And I was laughed out of the room. Well, in fact, 3 years ago, the American College of Surgeons went and visited the NRA at their headquarters at their national meeting to open this dialogue with them. And we went in that room. There were preconceived notions on both parties' part about what was going to come out of this session. And interestingly, we could agree on 12 or 13 things that we thought were at issue, that we needed the NRA's help with, and that they needed our help with. Been some turmoil in that organization. I'm not going to get into that part of it, but that group of folks that went to that meeting were all firearm owners from both sides of that equation, and they were really surprised about our approach to this. This is that team. There's a number of them that have military experience. There's a number of them that have law enforcement experience. All are trauma-trained surgeons. And this was the consensus document, the manuscript that we came up with. You've already seen this little sort of logo, if you will, about how to work together on this issue. And those recommendations were, as previously described, where we had achieved consensus. That if you're, and some additional things, that if you're a new gun owner, you probably should get some formal training in how to handle that weapon so you don't shoot yourself or harm someone else accidentally. That there probably should be required supervision for, and I grew up in a household where there was a loaded shotgun propped up against the back door. It was sort of built in as to how you learned about gun safety. I think we've lost some of that. It's possible to develop technology so you couldn't hurt yourself with a firearm. That would be miraculous. It's not going to do away with all the firearms that already exist, but it's a start towards a new future. And we have to get federally funded research opportunities to look into this problem. There are groups that work towards research in gun safety. And if you look at the burden of disease and death, only falls has a mortality and research funding level that's below gun violence. And if you look at what we've done for heart disease and cancer and lung disease over time, mortality is decreasing because we have applied our resources to those problems. We have not for gun violence. There are research organizations around the country that stand ready to do this. We had submitted a manuscript to 3 different organizations for presentation at their meeting, talking about what impact concealed carry permit has had on unintentional injury over time. No one would take it. I think too politically charged potentially is how they viewed that. Or that they didn't like the conclusion, because the conclusion is, surprisingly, that it hasn't changed mortality. It hasn't changed unintentional injury by having more concealed carry. We didn't know that going into this. We just wanted to study the problem, and we used a number of resources to do that. But we did it for free. We did it in our own personal time because there was no one willing to fund that. This is Dr. Ronald Stewart, the medical director of the American College of Surgeons Committee on Trauma, my partner and friend. And he has been to Capitol Hill on a number of occasions advocating for funding to investigate firearm injury and violence, to make the research efforts commensurate with the disease burden that this problem brings to us. There are other aspects of this, and again, not a psychologist by training, perhaps a psychologist by parenting and grandparenting. I don't know if that counts. But social structures that are in place in this country, not by design necessarily, potentially put people in harm's way. And how can we work towards solutions? I have told, if not one, then probably 4,001 young men, you need to find a better pastime. You have to get new friends, because this is going to get you killed. I would like to think that some of them heard that message, but there are plenty of recidivists that enter our trauma system with repeat injuries, and some of this has to do with how they were raised, where they live, literally who they hang out with. And that combination of poverty, mental illness, substance abuse sits right in the middle of this lethal triad related to individual risk factors for violence. And there's a certain potential level of hopelessness without, not protecting one's self for a future life that potentially leads one to unnecessarily put themselves in harm's way. Is it possible that we could screen people for violence? We do this because the Joint Commission that accredits hospitals around this country has put in place certain things that we ask people. I had the flu and I went to my emergency department and they asked me if I felt safe at home. Yes, I do. Thank you though for asking. Could you, put this in place in more than one? It shouldn't just be an emergency department thing. It should be every encounter with a healthcare professional about how one feels in their environment and are you safe or not. I think that could go a long way. Just as we have come up with injury prevention programs for falls and motor vehicles, there should be a violence intervention program. And so Rochelle Dicker and company from the American College of Surgeons have put together a comprehensive program for trauma centers. It's one of the things that they will be required to adopt in this country over the next 3 years. And there will be a verification that they have these programs in place and are working on this. It shouldn't just be trauma centers. It should be every encounter you have with a patient, a client, even in your church. It's uncomfortable to have these conversations, but if we don't have them, nothing is going to change. So it's not just the surgeons. In fact, after we were able to achieve our own consensus, we did a little outreach to some other organizations. And this is a group of individuals representing a number of medical organizations around this country, 47 in fact, who signed off on a consensus document. And this is everyone from the American Academy of Family Physicians through the Trauma Center Association of America, the American Psychiatric Association, the Emergency Nurse Association. So people from all disciplines working to care for our patients and prevent them from being injured. In a similar kind of a logo, those 47 organizations supported these statements, validating that in fact firearm injury is a public health crisis in this country, that the healthcare system must engage the community in addressing the social determinants of disease which contribute to this structural violence, and that we needed to engage firearm owners and populations at risk to develop programs and policies to address this issue. So in way of summary, I think that all of us should commit to action. That we have a certain responsibility, that we should do our best to work together, even with life members of the NRA, to address these issues, to reduce firearm injury and violence, and understanding violence and its determinants becomes paramount. That if we could get together, if we could have communion over these issues, we should be able to solve this problem. It's going to take a generational change and perhaps some radical change to make this happen. But without research funding, it's not going to happen. We have to engage our constituents if we're going to make a difference in this. So with that, I would like to again thank the OCAMPR organization for inviting me to speak here today. I would be happy to answer any questions that anybody has. Thank you.
Once you implement the screening questions that you propose or pass or are being practiced in your medical system, how do you, if the person answers yes to all those questions, what's then the action? What then? The set of questions that you included in your presentation for screening those whose lives involve daily, weekly violence and the ubiquity of guns and violence with them. If they answer yes to all those questions, or a good majority of them, what do you suggest then after that screening process, or what is the next step to engage the ED with and the trauma department with those who respond to those?
Yep, so I'm just a simple surgeon, and I'm going to do what I do every time an injured child comes in. I'm going to get the social worker involved to come see that. Who's the social worker? here, or a mental health professional, yeah. So I'm going to get those folks involved to have the discussions that I'm not armed to have. I don't solve those problems for people. I'll take out your appendix, I'll operate on your stab wound, but I don't know how to address your issues of safety and violence at home. The questions that we proposed, we actually said to the NRA, we don't know what the questions are to ask, and we would need your help in order to come up with a set of questions that might help us to understand if someone was at risk for this. And there's a group of folks that do nothing but injury prevention. Violence prevention is its own whole thing. I think we have this in interpersonal violence related to intimate partner violence. In many ways, there are places that people can go to seek safety, and we don't have that for this issue. We don't know what the magnitude of the problem. I don't know how many people are going to answer which question is positive at this point, because it's not been investigated. And so I think that the solutions will come from the question and answer session with those individuals over time. If anybody has answers to that, I would be delighted to hear it, because we could share that with the rest of the folks that are interested in this problem.
Thank
you. They need you to use the microphone so that. You could use this one.
Thank you so much for your presentation. Oh, okay. Now this feels... I wanted to know if you would talk a little bit about the Stop the Bleed program. I know you're going to be presenting tomorrow, I believe, about it, and I was in DC last week and heard some about it, and I think it would just be really great for us all to know exactly what that program is.
Sure. So the Stop the Bleed program came out of the Sandy Hook school shooting in Connecticut. And a friend and partner of mine, Lenworth Jacobs, and his team stood at the ready, as we did 2 years ago in San Antonio, to receive these casualties, and 2 showed up because everyone else was killed. And it was at that point that he said, just as an individual, I have done nothing to try to prevent this. We need to do something. And it caught the president's attention. And Dr. Jacobs made enough noise about it that he was invited to the White House to say, what can we do about this? There were 4 Hartford consensus groups that met. I was privileged to participate in consensus number 3. And what came out of that was that, well, we're going to need to do something about this whole preventing this from ever happening, but what can we do in the meantime? And that goes to that one slide that I talked about, turning bystanders into immediate responders. The difference between immediate responders and first responders is first responders have been trained to do this, and they do it as a part of their livelihood. Immediate responders is you and me. We're just there when something happens, and we can watch someone bleed to death, or we could try to do something about it. And it was some fascinating discussions about how long it would take, and where should we do this, and how would we go about it, to now today. The Texas legislature this past summer passed legislation that every school in the state of Texas has to have a Stop the Bleed kit and trained individuals in how to do it. If you look in probably every airport, you will find a Stop the Bleed kit, which contains gauze and tourniquets and some other things. Stopping bleeding is actually a scouting merit badge, and it doesn't take terribly long to learn how to do it. So in fact, you can give somebody about a 20-minute lecture and about 20 minutes of hands-on training, and they retain that knowledge for years, as it would turn out. I presented something like this in Minnesota, and one of the nurses who was out in Sleepy Eye, Minnesota, her fourth-generation farming family, decided that for Father's Day, she was going to get her dad a tourniquet to put in the combine. Little did she know, within 2 months he needed to use it on himself. And it was life-saving, game-changing, for those folks. And so the rule of thumb is, and I checked when I went in, there's a library in the other building. It has a little medical kit in it. They have an AED inside the bag, but they don't have a stop the bleed kit. So we're going to work on that for St. Peter's, for Saints Peter and Paul, to help get them outfitted with a stop the bleed kit. There are plenty of folks who bleed from causes unrelated to intentional injury. You can fall and break your arm and sever a blood vessel. Anybody who knows anybody on dialysis, those dialysis shunts can spontaneously rupture and cause someone to bleed. It doesn't take long to bleed to death. And that's what's at issue with that, turning those who are bystanders into immediate responders to teach them how to stop someone from bleeding to death.
As a pediatric intensivist who does the work along with our trauma surgeons, I thank you so much for this. I don't own a gun, but I have friends, family, colleagues who own guns or in the NRA, and your comments about language is tremendous. In the pediatric world, we've been asked to ask about gun ownership or having guns in the home for a long time, and usually if I would say, do you own a gun? You immediately believe that if you answer yes, I will have a negative impression of you. And so in pediatrics, in asking that question about guns, asking the question about vaping is not do you own or do you vape, it's how do you secure your guns? What do you vape? And then it takes away that negative connotation. So I think that language that you talked about and all of those questions are so important, because we all have biases, but in caring for our patients and interacting with each other, we have to set those aside, and our language matters. The one group of victims that you didn't talk about are those of us in healthcare that are exposed to these tragedies that happen to people.
Repeatedly.
Pardon?
Repeatedly.
Yes, repeatedly. And that is exhausting and emotionally permanent. How do you address that? And how do we keep our dedicated healthcare providers in this field to maintain their resilience so that they can continue to do the important work?
So one of the slides that I did not include in this presentation was a panel discussion where 3 interpersonal violence victims who were survivors addressed a group of healthcare providers, talking about their personal story and how thankful they were for that. Another slide I didn't include was a banner that we received from a hospital in Las Vegas following the shooting, talking about resiliency. You can overcome this. And so I think the combination of addressing this head on, acknowledging that it's an issue, and giving people an opportunity to see that even though not everyone can live through this, there are some that do, and how thankful they are for what we do on a daily basis, that it's worth continuing to persevere in this. We have a certain skill set, a talent for dealing with this. Not everyone lives. Death is a part of life. And the sooner we can come to grips with that, the better. The worst of the worst is to take care of a 1-year-old who's been shot to death. It just because all of the healthcare team has a 1-year-old, or they had a 1-year-old not that long ago. And it really brings it home and is personal. It's why we rely so heavily on our chaplains. And I need to remind them on a regular and recurring basis, you're not just here for the patient, you're here for us. We need your help. God bless the chaplains. I don't know who's there for them. Maybe some of the chaplains, but yeah, it's...
Thank you.
Yeah.
For me, my SWAT teams are there. As a chaplain, it is my SWAT teams and my wildland firefighters that, for the most part, I go talk to. Other than my confessor, it's not so much the many psychiatrists that I know. It is those who have smelled the breath of the dragon. On my badge, there is a black mourning band that indicates that a line of duty death of someone in my knowledge around the country. And over the last 2.5 decades, it has been, just a little statistic here, it's been on there more than it's been off. And something's wrong with that. My hat is off to those of you in ERs and so forth. In the aftermath of the shooting in Isla Vista, 23 May 2014, I was on the ground that night with law enforcement, and the day following debriefed with both UCSB police and Santa Barbara Sheriff's Department, and was asked by Dr. Jason Prostowski from Cottage Hospital, Santa Barbara emergency room, to come debrief the EMS staff. And I have often spoken of carpal tunnel of the soul, and there is a repetitive stress injury that happens to us whose little pea brains take pictures of those things and hear those sounds and have those intrusive fragments cataloged away in there. Tomorrow, while you're talking about stopping the bleed, I will be talking about carpal tunnel of the soul and things like that. And here again, it is peer support that is strongest, not abstractions, not concepts. It is someone who has smelled the breath of the dragon and walked away. And you can walk away and you can thrive. It is not something that's tattooed PTSD upon your forehead for the rest of your life. Otherwise, I'd have a lot of tattoos. And thank you, Doctor, for framing this as a public health question, because that's exactly what it is. Thank you.
Thank you.
And that's from a gun owner, incidentally.
Hi. Thank you, Dr. Jenkins, for framing the complexity of this as a public health issue. I'm curious if you can speak to, in some of the conversation that's been happening nationally, just sort of, if you can speak to how we might participate in that, and just as a clinical psychologist in a primary care clinic here on the west side of Chicago, we experience very high rates of violence and trauma, social determinants of health. The idea of the intentional injury and violence, you know, the need to allocate those resources and to really commit to think tanks and research to understand that. I'm just curious how we can partner and support in that, because in the world where I often am it feels as though there's the stream of the NRA and those that are operating from registered gun owners and sort of gun safety and all of that. But then where is the line of those who are not registering guns and illegal gun sale and gang violence? Where is that voice being heard and shaped into the conversation? And it just strikes me the idea of isolation, that there's multiple groups affected by intentional injury and violence. And just, yeah, if there's any way to speak to how we can be involved and engage and seek to promote hope as well as communion in the isolation that's all even just a part of the conversation, and who are the different stakeholders and who are those most vulnerable and most affected by that.
So I think as Grace addressed this last night in terms of how we have potentially isolated ourselves or allowed people to isolate themselves, that you can have a voice that's anonymous behind a screen and be violent in your language, be violent in your approach to things. Father Sean will tell you that having been deployed to the combat zone, soldiers who go out on patrol all day long, who are shooting at people and trying to prevent from being blown up, come back and play violent video games as a way of relaxing. We have muted violence as a problem. And if you just look at all of the violence in television shows and movies, it is just an acceptable way of being. You can undo that, and the analogy that I give people is it's not unlike so drunk driving is a horrible problem in this country, and people get killed and they kill other people. We solved, for the most part, a huge public health problem with smoking. In downtown Rochester, there's a restaurant called The Honker, and I use this example all the time. 20 years ago, if you walked in The Honker with a cigarette, they'd hand you an ashtray. Today, if you went in that restaurant and lit up a cigarette, the entire restaurant would turn on you. We have to make violence unacceptable. We can do that. It's going to take a generation and a concerted effort to do that. I don't know how to do that. I know that it's possible. And I think that the more that we think about it, have that dialogue with people, pray about it. I think that we stand a chance potentially of preventing unnecessary, and I think there's some necessary violence, what this doesn't touch on is that intentional violent death. Firearms are just about at the 50% level. The other 50% of deaths are related to other things. Violence is the common thread in all of that. We have to make that unacceptable.
Donald, thank you. You've shown us a way forward. You've told us that we've got to talk to both sides, and you've testified to the fact that these statistics have faces, and we thank you for that.